from the brilliant minds we have gathered. With that, it's my pleasure to introduce our PGY1 UAMS Walmart community-based pharmacy residents who will be leading today's presentation. Next slide, please. It's my pleasure to introduce our PGY1 community-based pharmacy resident, Dr. Gaurav Ohol. Born in Mumbai, India, Dr. Ohol has lived in 5 countries, bringing a truly global perspective to his work. He holds a Bachelor of Science in Biochemistry from the University of Arkansas, a Doctor of Pharmacy from UAMS, and an MBA from the University of Arkansas at Little Rock. His professional experience spans both independent and community pharmacy, and beyond pharmacy, Dr. Ohol enjoys walking, international travel, and baking. So welcome, Dr. Ohol. Next slide, please. We're fortunate to have not just one, but 2 outstanding residents with us today. Alongside Dr. Ohol, I'm also honored to introduce Dr. Nealee Weldon. Originally from Tifton, Georgia, Dr. Weldon discovered her passion for pharmacy early on while working at Walmart Pharmacy. She holds a Bachelor of Science in Chemistry with a minor in Sociology from Georgia Southern University and earned her Doctorate of Pharmacy from South University School of Pharmacy in 2025. She recently relocated to Arkansas to begin her PGY1 residency, where she is eager to expand her clinical knowledge while continuing to provide meaningful care within the community setting. Outside of pharmacy, she enjoys running, listening to audiobooks, and attending live concerts whenever she can. Please join me in welcoming Dr. Weldon as well. Without further ado, I will hand the presentation off to Dr. Ohol and Dr. Weldon. Next slide, please.
My apologies. Good evening, everyone, and welcome. Once again, my name is Gaurav, and I'm joined with my co-resident Nealee. We are thrilled to be here with you today presenting on improving vaccination rates across the lifespan. As PGY1 community pharmacy residents with the University of Arkansas for Medical Science and Walmart, we consider it a tremendous honor and privilege to lead this discussion and presentation today. Vaccination is not just a clinical service, it's a cornerstone of public health, and we are passionate about exploring with you how pharmacists can drive meaningful, measurable improvements to immunization rates across every stage of life. Next slide, please. So before we begin our presentation to the core content, we wanted to take a moment to review some objectives we'll be covering today. First, we want to identify common barriers to vaccinations in pediatric, adolescent, and older adult populations. We want to be able to differentiate between the various types of barriers. Then we want to analyze patient-specific factors that influence vaccine acceptance and uptake. Finally, we want to implement targeted strategies to overcome vaccination barriers across diverse populations. And for this presentation, we will define pediatric and adolescent patients as patients age 17 and younger, and we will define older adult populations as those patients age 65 and greater. We want to highlight these groups specifically as they're 2 patient populations that have the highest rate of hospitalizations resulting from misvaccinations. Next slide, please. Here's a roadmap for today's presentation. We'll start with an introduction, then move into barriers across pediatric, older adult, and cross-population groups. Then from there, we'll discuss strategies pharmacists can use to improve vaccination rates, and finally wrap up with a conclusion and a Q&A. With that, I'll kick it off with Dr. Nealee.
Hello. I can't see the slides anymore, but I've got them up on my screen. So we're going to start with pediatric and adolescent. Can you mute? Sorry, I was hearing my own echo. We're going to start with pediatric and adolescent. So for the pediatric and adolescent vaccination, this lays the foundation for lifelong immunity, yet coverage data show early warning signs of plateauing or decline in some critical vaccinations. National surveillance and state immunization registries reveal that while infant and early childhood vaccines like DTaP, MMR, and polio generally stay above 90% completion, adolescent boosters and multi-dose series such as HPV lag far behind. These gaps create a measurable rise in susceptibility to outbreaks of measles, pertussis, and meningococcal disease. One of the biggest structural differences between pediatric, adolescent, and adult care is the transition point around adolescence. In childhood, vaccinations are tied to routine well-child visits, but during adolescence, preventative care becomes sporadic. Many teens don't see a primary care provider annually, and well visits are missed or replaced by sports physicals that may not include immunization review. This creates natural points where vaccinations fall off the radar. Pharmacies and other community touchpoints therefore represent an untapped channel for adolescent immunization. Teens and parents already come to pharmacies for over-the-counter products, sports physical paperwork, and chronic meds like inhalers, and each of these visits is a chance to assess vaccination status and close gaps. The primary barriers we will discuss today for the pediatric and adolescents include parental hesitancy, misinformation, and mistrust, access and scheduling constraints, provider and system barriers, as well as policy and exemption challenges. When it comes to parental hesitancy, mistrust, and misinformation, the National Immunization Survey, or NIS Teen, in 2023 reported about 23 to 25% of parents of adolescents express hesitancy toward at least one recommended vaccine. Studies show parental hesitancy correlates strongly with delayed or refused HPV, Tdap, and MMR vaccines. So it'll be the next slide. Yes, the American Academy of Pediatrics notes hesitancy clusters geographically, which creates hotspots of undervaccination. Some key drivers identified in the literature include fear of adverse events or overloading the immune system, belief that diseases are rare or non-threatening, influence of misinformation on social media, distrust of pharmaceutical companies or government recommendations, and the impact of this we can see where hesitancy is high, HPV completion lags by 15 to 20 percentage points, and Tdap boosters by 5 to 10 points compared to national averages. Next slide, please. For the next barrier, we have access and scheduling constraints. So research from the CDC's National Center for Immunization and Respiratory Diseases shows missed well child visits and poor access to after-hours care are major contributors to lower adolescent vaccine uptake. Adolescents in rural areas are 25 to 30% less likely to receive vaccines on time than urban counterparts, and families with Medicaid or uninsured status have higher missed dose rates. Key factors identified in the literature for this barrier include transportation barriers and limited clinic hours, parental work schedules making weekday appointments difficult, adolescents aging out of pediatric care and not transitioning smoothly to adult providers. And then for the impact, we can see areas with fewer providers per capita show lower HPV and meningococcal vaccination rates, and scheduling inflexibility leads to significant missed opportunities, especially for these multi-dose series. Next slide, please. The next barrier we have was provider and system barriers, and this can be seen in inadequate provider recommendation strength. A national survey from the CDC in 2022 showed that parents who receive a weak or optional recommendation are twice as likely to defer or refuse vaccines compared to those receiving a strong recommendation. HPV coverage rates vary dramatically depending on provider communication, and in clinics where staff consistently deliver strong recommendations, uptake can exceed 80%. However, where staff are hesitant, uptake may be less than 50%. Some key drivers identified in the literature for this issue include time-pressed visits leading to skipped or rushed vaccine discussions, provider discomfort discussing sexual transmission for HPV, or lack of prompts or checklists to remind clinicians of due vaccines. For the impact of this, we can see that provider inconsistency contributes to regional variability, and there are persistent coverage gaps despite vaccine availability and insurance coverage. Next slide, please. Our third barrier that we had for the pediatric and adolescent population was policy and exemption challenges. So for non-medical exemption rates, they have increased from about 1.5% nationally in 2010 to over 3% in some states by 2025. Studies in pediatric and health affairs show exemption clustering amplifies outbreak risk, even when average coverage remains high. For example, communities with high exemption rates experienced larger measles outbreaks in 2018 and 2019. Some key drivers of this identified in the literature included broad religious exemptions allowed by some states, weak enforcement of school entry vaccination requirements, and lack of robust immunization registry integration, which makes it hard to track who is unvaccinated. And for the impact of this, we can see in counties with exemption rates greater than 4%, herd immunity thresholds for measles and pertussis are compromised, which can result in localized outbreaks. Next slide, please. For this one, we have a poll, and this is just food for thought. So, what do you think is the most critical barrier to improve vaccination rates among the pediatric and adolescent population? So, first we discussed parental hesitancy, misinformation, and mistrust. The second one was access and scheduling constraints. The third one was provider and system barriers. And then we last talked about policy and exemption challenges. So, obviously, this could depend on your patient population and your patients in general, and this is just food for thought. There is no right or wrong answer for this one. Next slide, please. Now we will talk about the older adult population. Adults age 65 and older face the highest risk from vaccine preventable diseases due to weaker immune systems, multiple chronic conditions, and frequent healthcare exposure. Vaccination in this group prevents severe illness, hospitalizations, and loss of independence. Despite higher coverage than younger adults, large gaps remain, especially for shingles, Tdap, and now RSV, and disparities persist across race, ethnicity, and geography. Pharmacists play a pivotal role because seniors regularly visit pharmacies for chronic medication refills. Every interaction is a chance to screen, educate, and vaccinate, and by focusing on older adults, we can preserve quality of life, reduce cost, and protect community health. For the barriers to vaccinations in older populations, we had 6 of them. The first is cognitive decline and memory issues, then misconceptions about vaccine necessity, inadequate integration of vaccination services, variability in vaccine recommendations, relaxation of vaccine mandates, and social isolation. Next slide, please. First, we will discuss cognitive decline and memory issues. Age-related cognitive impairment or dementia limits an individual's ability to recall vaccination history, understand recommendations, and follow through with multi-dose schedules. Older adults with cognitive decline are less likely to be up to date on preventative care, including vaccines, and caregiver involvement strongly predicts vaccination completion. Without proactive caregiver engagement or systemic pharmacy prompts, these patients easily fall through the cracks. Next slide. Next, we have misconceptions about vaccine necessity. Some older adults believe vaccines are for children or that past infection or previous doses provide lifetime immunity. Others assume their current health status exempts them from the need. Surveys show low awareness for shingles, Tdap, and RSV recommendations among seniors despite high awareness for flu. Misconceptions fuel complacency, which translates directly into under-immunization. Pharmacists must position vaccines as age-appropriate and ongoing instead of one-time childhood events. Next slide. Next, we have inadequate integration of vaccination services. Vaccines for seniors often require multiple settings, such as primary care, specialists, and pharmacies, and records may not flow between them. This fragmentation obscures eligibility or duplicates or delays vaccines. Gaps between Part B and Part D billing and lack of interoperable immunization registries frequently deter providers from offering all recommended vaccines at once. And seniors experience logistical barriers, appointment fatigue, and confusion about where to receive vaccines, resulting in missed opportunities. Next slide, please. Next, we have variability in vaccine recommendations. Changing guidelines, such as the new pneumococcal conjugate vaccines or the new RSV recommendations, can confuse both providers and patients. Inconsistencies between the CDC, state, and insurer communications create hesitation. This can be seen in shifts from PCV 13 to PCV 15 or 20, or the introduction of RSV vaccines, which show slower adoption due to message complexity. Without consistent, unified messaging, uptake lags, even when the vaccine is beneficial and covered. Next slide. Next, we see relaxation of vaccine mandates. There are fewer mandates for adult immunizations, especially compared to school entry requirements for children, and this removes an external driver for compliance. Adult vaccines rarely have enforceable mandates, so uptake depends on voluntary behavior shaped by access, trust, and awareness. The absence of a default requirement makes adult vaccination a discretionary activity, and strong system-level nudges are needed to mimic the effect of these mandates. Next slide. Lastly, we have social isolation. Socially isolated older adults have fewer touch points with healthcare providers, less exposure to public health messaging, and reduced peer influence. Studies link social isolation and living alone to lower uptake of flu, pneumococcal, and shingles vaccines. Outreach has to actively bring vaccines to isolated seniors via home visits, mobile clinics, or linkage with community organizations. Next slide, please. This is another poll. So again, food for thought. You can either think about it, send it in the chat, however you feel. So what do you feel is the most critical barrier to address to improve vaccination rates among the older adult population? So we discussed cognitive decline and memory issues, misconceptions about vaccine necessity, inadequate integration of vaccination services, variability in vaccine recommendations, relaxation of vaccine mandates, or social isolation. Next slide, please. I will kick it off back to Gaurav.
Awesome. So this section shifts our focus from age-based groups to cross-populations. And when we look at cross-populations, we're looking at how social, cultural, and systemic factors shape vaccine uptake across communities. Because this is a NHPA webinar, we felt that it's important to highlight why this lens matters for Hispanic and other underserved populations as well. And when we talk about cross-populations, we're recognizing that barriers don't just stop at an age cutoff, but geography, language, immigration status, race, and ethnicity, even insurance type and disability are also, and social determinants of health are all intersect to influence vaccination rates. The patterns we've seen, whether it be pediatric, adult, or older adult, all carry fingerprints for these broader forces. Next slide, please. So when we talk about vaccination disparities across the United States, there are three main populations we want to focus on: Hispanic populations, African American populations, and American Indian / Alaska Native populations. These groups consistently experience low vaccination rates compared to the national average, as reported by the CDC and the Kaiser Family Foundation. The reason behind these gaps are not about willingness or awareness alone. They're rooted in systemic inequalities, cultural barriers, and access challenges that have persisted for decades. Next slide, please. So when discussing vaccination barriers among Hispanic populations, it's essential to recognize that these challenges are multifaceted, and they're shaped by language, access, and socioeconomic status, as well as the trust in the healthcare system. So first, when we look at language and healthcare literacy gaps, it remains one of the most significant barriers. According to the CDC and the Journal of Immigrant and Minority Health, limited English proficiency and low health literacy often results in misunderstandings about vaccine safety or schedules. Pharmacists who provide bilingual education, Spanish language consent forms, or culture relevant material have been shown to improve vaccine acceptance rates substantially. Second, we can look at limited access due to work schedules or transportation barriers, and these continue to hinder preventative care. Many Hispanic adults work essential or shift-based jobs with inflexible hours, making it difficult to attend traditional clinic appointments. Third, immigration status and insurance concerns play a critical role. Research from the Kaiser Family Foundation found that a fear of data sharing, deportation, or ineligibility for public programs prevent many from seeking vaccines, even when they are free. Fourth, cultural perceptions and historical mistrust also affect vaccine confidence. Past experiences of discrimination or neglect have created skepticism towards the healthcare system. And lastly, underrepresentation of clinical and public health outreach means Hispanic communities are often left out of research, messaging, and leadership opportunities. Next slide, please. When discussing vaccination barriers in African American populations, it's crucial to recognize that these challenges stem from a complex mix of historical, social, and systemic factors. First, there's a deep-rooted historical mistrust of the healthcare system, shaped by unethical practices such as the Tuskegee syphilis study and ongoing disparities in treatment. Research in the Journal of General Internal Medicine shows that this mistrust continues to influence vaccine hesitancy today, not because of a lack of knowledge, but because of a lack of trust. Second, access gaps and transportation challenges remain a real issue. Studies from the CDC reveal that African Americans are more likely to live in areas with fewer health facilities or pharmacies offering immunizations. Third, insurance and cost barriers continue to limit preventative vaccines. While many vaccines are covered under federal programs, confusion around eligibility, coverage under Medicare or Medicaid can still prevent individuals from seeking care. And finally, cultural perceptions of misinformation spread rapidly, particularly through social media. Studies from the American Journal of Public Health highlight that tailored education using culturally resonant messaging and trusted community voices rather than general public health campaigns can be more effective at combating misinformation. Next slide, please. Oh, finally, we wanted to talk about Indian American as well as Alaska Native populations. So there's a longstanding mistrust of government and healthcare systems stemming from a legacy of medical mistrust and broken promises. According to the CDC, this historical trauma continues to influence vaccine hesitancy in many Native communities. When we look at geographic isolation, it's another major factor. Many individuals live in rural or remote areas, which significantly limit access to clinics and pharmacies. The Indian Health Service has emphasized how this impacts vaccine delivery, particularly in areas of Alaska. In addition, the Indian Health Service itself is chronically underfunded. The Government Accountability Office has repeatedly identified IHS as a high-risk agency due to resource shortages, which hinder its ability to respond quickly to health emergencies. And finally, when we look at language and cultural barriers, they also play a role in health communities and are not always culturally appropriately or translated into native languages, which can limit the understanding and trust, as reported by the Urban Indian Health Institute in 2021. Now we have another poll, so this is some food for thought. Which barrier do you feel impacts cross populations the most in your area of practice? I have language and literacy gaps, limited access / time due to work schedule, insurance issues, or if you wanted to share one in the comments, we'd be happy to read it. Next slide, please. Now we want to compile all of the barriers that we've discussed in this presentation and discuss strategies for addressing these barriers. Next slide, please. So research consistently identifies 4 major strategies to address vaccine barriers in pediatric and adolescent populations. First, parental hesitancy remains a leading obstacle. Studies from the CDC and pediatrics show that concerns about safety, necessity, or morality, particularly around the HPV vaccine, often delay preventative vaccination. So evidence suggests using presumptive language or motivational interviewing paired with bilingual and culturally tailored educational material can improve vaccination series completion and rates by up to 20%. Second, access challenges such as transportation barriers, work schedules, and fewer routines to pediatric visits limit opportunities for vaccination. Research in the American Journal of Public Health highlights that after-school or weekend clinics, integrating vaccines into sports physicals or back-to-school events, and offering a one-stop catch-up opportunity can significantly increase vaccine uptake. Third, a strong and consistent provider recommendation is the most powerful predictor of vaccination according to the National Immunization Survey for Teens. Whether it be pharmacists, pediatricians, and clinic staff, delivering confident, standardized messaging and increases same-day vaccination acceptance rates sharply. And finally, addressing cultural and policy barriers is essential. Studies from the Journal of Community Health show that language differences, cultural norms, and religious beliefs contribute to under-vaccinations. But partnerships with schools, faith-based organizations, and community leaders, along with advocacy for evidence-based exemption policies, help to build trust and promote equitable vaccine coverage across populations. Next slide, please. So research highlights several strategies for overcoming vaccination barriers among older adults. First, mobility limitations and caregiver dependence often prevent seniors from accessing vaccines. According to the American Journal of Preventive Medicine, implementing mobile vaccination units, offering home visits, or pairing vaccines with medication delivery services have been shown to improve immunization rates among homebound and long-term care populations. Second, comorbidity complexity can complicate scheduling and prioritization of vaccines. Studies published in Vaccines suggest that synchronizing vaccine appointments with medication reviews and simplifying the process through pharmacist-led coordination increases adherence and reduces confusion. Third, insurance confusion, particularly distinguishing between Part B and Part D Medicare coverage, creates a significant barrier. Research from the Journal of the American Pharmacists Association emphasizes that pharmacy staff trained in Medicare billing and coverage navigation can help guide seniors effectively at the point of care, reducing missed vaccinations due to cost or misunderstandings. Now, finally, disparities among minority and rural seniors persist due to language, culture, and geographic barriers. Evidence from the CDC and the Journal of Community Health support targeted outreach using culturally and linguistically appropriate communication, which builds trust and improves vaccine equity among underrepresented older adult populations. Next slide, please. Finally, we wanted to address barriers across cross populations. So research identifies several system-level strategies to reduce this. So first, we can look at transportation barriers, language differences, and lack of culturally competent outreach, which continues to limit vaccine access, especially among seniors or minority groups. According to the American Journal of Public Health, forming community partnerships with senior centers, churches, and local nonprofits can help with transportation, translation, and outreach in vaccine community events. And this shifts it from community-supported events rather than clinic-based transactions. Second, systemic mistrust remains a critical barrier rooted in historical and ongoing inequities. Studies from the CDC and Health Affairs show that engaging trusted community figures such as faith-based leaders, civic groups, and ethic associations help shift the message from the healthcare system to trusted familiar voices, significantly improving vaccine uptake. Third, policy fragmentation across states, such as variations in pharmacist authority, insurance coverage, and immunization registry access, create inequitable vaccine opportunities. Research from the Journal of the American Pharmacists Association suggests that harmonizing pharmacist immunization authority or educating communities on the local vaccine resources reduces missed doses and supports equitable access. Lastly, the digital divide poses a modern challenge. Pew Research Center data shows that nearly 1 in 4 older adults in cross populations lack reliable internet access. So implementing a dual community strategy combining phone calls with mailers with digital tools like texts and apps ensure vaccine outreach remains inclusive across generations and socioeconomic groups. Next slide, please. So finally, we wanted to bring it all together in these next few slides. So pharmacist-led vaccinations have profound impact on both public health and the economy. According to the CDC, studies published in the Health Affairs, pharmacist vaccination programs prevent tens of thousands of hospitalizations annually, particularly for influenza, pneumonia, and COVID-19. Expanding vaccines across through pharmacies has been shown to save billions of dollars each year in the healthcare costs and productivity losses by reducing disease burden and preventing work absences. Moreover, research in the American Journal of Managed Care highlights that pharmacist-led vaccination efforts free up valuable physician time and public health clinic time, allowing providers to focus on managing chronic or complex conditions. Finally, by improving access and uptake, pharmacists play a key role in building community resilience against outbreaks, ensuring faster, more equitable immunizations responses during public health emergencies, and enhancing overall population immunity. Next slide, please. So pharmacists are becoming more accessible and cost-effective solutions for expanding healthcare access. By continuing to grow authority over all age groups, pharmacists can offer more services like vaccinations, chronic disease management, and medication counseling, often at a lower cost than traditional settings. Integrating AI tools allows pharmacists to identify at-risk patients earlier and conduct targeted outreach, reduce expensive emergency visits. Affordable care also depends on collaboration, whether pharmacists working with public health, technology companies, and insurers, they can streamline care and deliver to improve outcomes. ultimately positioning pharmacists as a front door to preventative care, helping people get the help they need sooner, more conveniently, and at a fraction of the cost. Next slide, please. So if there's one thing we hope you carry away with you from this presentation, it's that vaccination gaps are both predictable and fixable. No matter the age group, cultural background, or reason for hesitation, barriers can always be addressed with the right approach. Vaccination success depends on trusted local engagement. Pharmacists are most common and consistent access point across the lifespan, whether it's caring for children, adults, or older adults. Nearly everyone comes into contact with the pharmacy at some point, and every one of those moments is an opportunity for potential life-saving conversations. Next slide, please. So we just wanted to say thank you so much for listening to our presentation. We wanted to thank NHPA and our amazing co-hosts with us today for organizing this webinar and giving us the opportunity to present. We also wanted to thank Dr. Perez for moderating, and Dr. Brandy Rios and Dr. Stacy Zuleta for reviewing and assisting in our presentation. And we have a QR code that's listed out, as residents were required to complete a teaching certificate for our program. And thus we humbly request if you can take a moment after the presentation to complete the survey for us. Thank you. And we're happy to answer any questions.
Great presentation. Thank you so much. Can you hear me okay?
Yes.
So we have the first question, so I'll go ahead and read it out loud to you. What can we do as future pharmacists to reduce the barriers and challenges Hispanics face compared to the other racial groups? In El Paso, many individuals who cross the border struggle to access expanded vaccines because of high costs, sometimes over $500 per dose. How can pharmacists help improve access and trust in these situations? So Nealee and Gaurav, if you want to kick it off, if you'd like to expand on that answer after you're done, once you are completed with your webinar, you totally can, and we can definitely get those answers out. But if you have some thoughts that come top to mind, I'll let you have the floor.
Yeah. First, for me, one of my first thoughts with this question is that it's a great question. I think one of the first things we can do as pharmacists is provide them access to the platforms they need in order to get the vaccination covers. So getting them access to either saving cards that might reduce the cost, coupons that might be able to help, or getting them in touch with Medicaid representatives that might be able to help with insurance coverage is usually what my first reaction would be if I was faced with individuals who are struggling to have coverage for expanded vaccines. A lot of the time as pharmacists, all we can do is give them the tools to help them. And that's usually the way that I would go about helping these patients.
Can you hear me okay? Okay, perfect. Awesome. And so there were a lot of ideas that came out of that presentation. I can tell you that I'm an El Paso native myself. And so coming from El Paso, Texas, living on the border, we have a lot of diversity as it pertains to our patient population. And so we have a lot of barriers and challenges, not even just from a language barrier, but definitely from a cost barrier. So people who cross the border, I always, from a pharmacist perspective, really try to always have in hand or as a favorite on my computer free vaccination clinics. And so if they can't apply to Medicaid, they can't apply to Medicare, and there's someone who's crossing the border or new immigrants, I always had resources at my fingertips where they could either call or I could help them call local clinics. And so if you need more help with that, I'm always free and available. I'll put my email in the chat. As an El Paso native, I can definitely understand how this can be a barrier. And I love when P1s are so anxious, wanting to help that patient population. But I can definitely understand when someone's coming from a different country, how it presents a different barrier. And so happy to share those resources with you. But I would tell you that immunize.org has resources available. CDC has resources available. And then El Paso County has resources available, and that's across the state. So if you look at the human health services websites, many times they also have links to free vaccine clinics where the patient would have to enroll themselves and register. Great question. We have another question that's come through. So Tessa Lerazo, so what are some effective ways to approach parents who are hesitant about vaccinations, especially when they've been influenced by misinformation? I'm a learning P1, and knowing some strategies for this would help when it comes down to counseling. So Gaurav or Nealee, would you like to take that? So this is as it pertains to parents who have some hesitancy or maybe have some misinformation that they're presenting to the pharmacist at the consult.
Yes, I feel like that one, it really comes back to the motivational interviewing, being a resource for them and telling them that it is ultimately their decision, but having that strong recommendation of, as a healthcare provider, this is what I would recommend based on these facts. And if you have questions, I'm always a resource here for you. So if you have any questions, I'm here for you. I do recommend that they get it for these reasons. Ultimately, it's your decision, but we are here as a resource and a guide for them. I think it all comes back to the motivational interviewing, being a resource and telling them that you're always available to answer any questions they have.
Definitely love that. So always being a resource. I definitely love that. I think one of the things that I love about our profession, and it is Pharmacist Month, so happy Pharmacist Month out there for all of our pharmacy teams, including our techs and all supporting personnel, but really leading with empathy, right? And so really for me as a pharmacist, I always want to ensure that I understand why they feel that they have certain information that's accurate. And I really try not to jump to conclusions. So I always ask for permission. Would you be interested in learning a little bit more about this vaccine? And I really don't try to overburden the patient with a lot of information. I always let them know that my door is open. They can always call me. They can always come back if they want to noodle on something and think on it. But really, I always try to lead with empathy to understand what are they worried about and what is the information that they have at hand. I can tell you that as a pharmacist that practiced in El Paso, Texas, we had a lot of hesitancy over HPV vaccines, for example. And so really just making sure that parents understood that HPV was a skin-to-skin infection and nothing else, and that it prevented cancer long-term was really an eye-opener for a lot of parents because there was a lot of stigma around that vaccine and things of that nature. And so I think really for a pharmacist perspective and a P1, I really can appreciate the question. I love the enthusiasm. And I think really making sure that you have empathy and that you're trying to understand your patient, right? Like you're trying to understand where they're coming from so you can change how you're going to communicate with that patient. Every patient's going to be different and not everyone's going to be the same. And again, I want to stress as well that that we talk to patients in a manner that is not like downgrading or the medical jargon is so high above someone's head that they're not understanding you either, because that does build mistrust. So I appreciate the question. I would say come from a place of wanting to help the patient, and it seems like you're already on your path and on your way. So I can appreciate that. But really coming from that place of understanding. And I think that's any relationship, right? If you can understand why someone has hesitancy or they're afraid or maybe they're worried. I'm a mom too. And so I couldn't imagine that someone would be stressed about giving someone a vaccine that's a child, understanding where they're coming from, and then putting it in those words, right? So this is just a skin-to-skin infection. It is nothing else and nothing more, right? And so it's going to help prevent cancer long-term. And so I always used to ask moms and dads, like, do you want to protect your kids from cancer? Like, I would definitely love, vaccines that can protect kids from cancer. So really coming from that place, I think is going to take you very, 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 very far. Love the questions. Anyone else out there have any other questions? You're welcome, Tessa. Thank you guys for answering all the questions. We'll give it one more minute to see if there are any other questions that come through. Any closing thoughts from you guys? Nealee or Gaurav?
Thank you all again so much. I sent the link for the teaching evaluation in the chat if you missed the QR code.
Perfect. Well, thank you, NHPA, so much for supporting our pharmacy residents, for supporting such an important topic in these times in terms of vaccinations. We have all of your contact information. I will chat in my email, so you guys are always welcome to reach out to me if you have questions or want to just reach out and chat further. I'm doing that right now. But please feel free to reach out if you would like to connect outside of this Zoom call. Happy to do that as well. But again, happy Pharmacist Month. Thank you for taking your time to join us today, and thank you for being generous with your time to sit in on this talk with us. And if you have any further questions, feel free to reach out. Otherwise, I'll pass it over to NHPA.
Wonderful. Thank you so much. Thank you for everyone. This has been a wonderful presentation. And we'll make sure to upload the webinar to our website so everyone has access to it. Okay. Thank you. Have a good evening,
Sounds good.
everyone.
Thank you. Have a good evening. Thank you.